A warm welcome from Germany to all the guests tonight. I'm very honored that I have the ability to talk about mesothelioma surgery. You know, I'm from Turkish origin, even if I was born in Germany. Therefore, it fulfills with me with honor. Thank you very much. And I don't want to waste your time because we are at the evening and you all had a very tough time at your workplace today, most probably. Therefore, I will go straight forward that we can have nice discussions at the end, most probably. I have no conflict of interest with regard to this presentation. I want to talk about epidemiology in Germany because it's interesting. In every country, the epidemiology is quite different. To understand the philosophy of each country, it's important that you also know facts about epidemiology. If you look at the data in Germany, we have almost 1,600 new cases per year. And you see it's predominantly male patients faced with this dismal disease. And compared to that, we have almost 1,450 deaths per year because of mesothelioma. And you see the 5-year survival rate is quite different. The female gender has a survival advantage in this kind of disease. If we look at this public transportation bus, it has a capacity of approximately 100 people. That means every year we have 16 buses full of people diagnosed with mesothelioma. It's a quite huge number, but at the end of the year, only 3 buses left with patients still alive after diagnosed with mesothelioma. If we look at the non-surgical treatment options, excuse me, it's not complete, but to give a favor for you, if we do nothing, mostly these are very patients in very advanced age. They have a median survival of 7 months for best supportive care. If we apply only chemotherapy alone, it's about 1 year. And if we apply immunotherapy, then we have about 14 months median survival. And there is a lot of combinations possible with different medications, but not all possible medications are available in all countries all around the world. And we have to know that a doublet immunotherapy can also be very dangerous with a mortality rate of about 5.6%. Therefore, if we put all things together, we have a very dismal disease. And I try to follow the advice of Hippocrates. As to dismal diseases, make a habit of 2 things: to help or at least do not harm. Therefore, the advice would be do not harm to your patients. Before we come to, or to try to answer these questions of the presentation, I want to go back and talk about the paradigm shift. Why? You know, there was an ongoing discussion about what kind of surgery, but nowadays we see more and more centers do adopt less invasive surgery, like this paper from Professor Batirel from Istanbul, and with you all colleagues together, we see here, even if you do less invasive surgery, the similar is at least similar or even better. And you know, the Zurich group, Professor Weda was an advocate of EPP, and even at this center, they made a paradigm shift and shifted towards less invasive surgery, showing, okay, there is an free from recurrence time of 3 months compared to 15 months, but at the end, the patients survive longer. At the beginning, there was a smart euphoria. That means we had no median survival time because the curve was not crossing the 50% line. And we were very enthusiastic about the new possibilities about this more extensive disease. However, it was the first outcome examination about this protocol with a follow-up of 23 months with no median survival time and a 3-year cumulative calculated time of 84%. But in the next paper, we saw if you include more patients to the study protocol, then you end up with 28 months. That means also in the same range as every other treatment protocol before. If you look at this data from Hasegawa et al. From Japan, they made also an adoption. They made an adoption from EPP to less invasive EPP. Less invasive means if it's not necessary, the diaphragm will be left in or the pericardium will be left in. And if they do this less invasive approach, they have a better progressive free survival and median survival. And if they do PD, they have the best overall survival. But if you look at this data, you cannot compare different countries because there is a different asbestos exposure, different gene expressions, etc. So they have very good data, but it's not comparable to Germany or to Turkey or to Great Britain. If we talk about surgery, we have always keep in mind that mortality and morbidity is very important to keep in mind. If we look at systematic analysis, morbidity and mortality is lower if we apply less invasive surgery. And we want less invasive surgery with less morbidity and mortality. Therefore, we can adopt some surgical issues which might be important. If you do a complete EPP, then you can make this thoracic shaping technique. That means that you're after resection of the diaphragm, you reconstruct the diaphragm a little bit higher, that the cavity is smaller, that the lung gets attached to the chest cavity, and the prolonged air leak stops. What we do nowadays is that we avoid using Gore-Tex materials, because at this areas, there is no attachment of the lung with the surrounding tissue, that in these areas, most probably you have complications due to prolonged air leak. We use usually laser when we perform pulmonary metastasectomies. It has the ability that you can cut through lung parenchyma, but at the same time, it seals the lung tissue to avoid prolonged air leak. Therefore, we apply this also in mesothelioma surgery. Here we have a typical patient with right-sided mesothelioma, ectoloid histology, after minimal invasive tissue obtaining and fluorodesis. Then we do our usual approach. And if we go to the basilar segments, then we use the laser so that we can cut through the lung and seal at the same time. I go a little bit further. Then you see here we have the tumor. This is the diaphragm and the tumor. And then you can separate the lung from the underlying tumor without great blood loss and with sealing of the lung. And at the end, then you have such kind of specimen. You get all the tumor out, but leave the lung back, and you have a sealed lung in the basilar segments. So if we come to the questions, before, after, or never. What about the role of patient selection? At the IMIC meeting 2014 in Cape Town, we presented our data with a so-called meso score. This was created by our group, and we looked at the patients, and we had only three factors: early stage, advanced stage, histology epithelioid or non-epithelioid, age below 70 or above 70, and each of the issues could get 1 point. At the end, you can get 0 to 3 points. And if you look at the data, if we choose the best patients, it was only about 20 patients. That means young age, epithelioid histology, early disease. If we only operate on these patients, we can get incredible median survival times. But on the other hand, if we do not care about these important prognostic factors and choose a very elderly patient with a sarcomatoid histology and with advanced stage, we end up with 6.3 months. That means we do harm. Even if you have 2 points, you end up with 13.6 months median survival. That means it's the same like chemotherapy or immunotherapy alone. That means the patient has no benefit if you apply him and offer him surgery. That means, yeah, we know when we should never perform surgery. In our situation, in these patients with all the negative prognostic factors. Therefore, please do not harm and do not operate on patients with all the prognostic negative factors. But go for surgery if you have the right patient, if he has only 0 points or 1 point. You know, we are right before IMIC 2021, and we looked our data. It's only a poster presentation at IMIC, therefore I can present you 2 slides. We looked at our data. We used all the known facts for patient selection, and we used all the possible surgical techniques. And if we look at the histology, patients with epithelioid histology had a median overall survival of 35 months. On the other side, patients with non-epithelioid histology, only 10 months. How could this be if we knew it 7 years before? This is the fact that we have only, mostly at initial diagnosis, we have only patients with very small biopsy specimen that you might have a region with only epithelioid histology, but at the end, when the pathologist have a huge tumor volume and do his examinations, you could end up with biphasic or sometimes sarcomatoid. The same is true for progression-free survival. If you have epithelioid histology, they have a progression-free survival of 15 months compared to 9 months. Before or after is the next question. This is my personal view. We are not able to apply the same oncological principles for mesothelioma as explained in this picture. If we operate colonic cancer, it's on the right colonic side. It's only a small tumor. Even at this situation, we perform a hemicolectomy. That means we have a lot of safety margins. If you look at this disease, dismal disease of mesothelioma, then we see within a few millimeters, we have a lot of different specimens. That means we are not able to have safety margins. That means we can only go for macroscopic complete resection. At the end of the surgery, you do not see any tumor left behind. You do not palpate any tumor left behind. But if you go in detail, you might have microscopic incomplete resection. That means this knowledge would favor an systemic treatment in the adjuvant fashion, because you do not get out with microscopic and complete macroscopic and microscopic complete resection at the end of surgery. What is the role of surgery in this dismal disease in general? There are mathematic examinations. This was a work from Utley et al. From Great Britain. And if they use our big database and they have different groups of patients, if you have a group of patients with including cancer-directed surgery, these patients have about an advantage, a survival advantage of about 8.5 months. This is a comparable examination of a database of 25,752 patients, and they had a group of patients with no therapy to the last group of three modality treatment. I'm sorry that it's very small to see for you, but if you look at the data, it does not matter if it's epithelioid, biphasic, or sarcomatoid. If you can apply cancer-directed surgery, these patients have a survival benefit. It's statistically significant for epithelioid and biphasic, but it's not statistically significant for sarcomatoid tumors. And if you look at this examination of Nelson et al. In detail, we can look at the stages, irrespective what stage. If you can apply three modality treatment, the patients have a benefit for such kind of surgery. If you look at the histology, then you see even if they have sarcomatoid tumor, they have a survival advantage. But once again, 10 months means less than 12 months if you apply only chemotherapy. I would not recommend to apply cancer-directed surgery if you have the specimen before surgery and it's clearly sarcomatoid tumor. It's also true if you have biphasic. It's only 14 months. What about the international guidelines? Before, after, or never? Then we can look at the NCCN guidelines from the United States. We have no answer. That means you can start with surgery upfront, but you can also start with induction chemotherapy upfront and go for surgical exploration. In my personal view, I don't see any role for induction chemotherapy. Why? If someone is at borderline, that means you do not have the clear answer if you can get a macroscopic complete resection. It does not become better if these patients undergo induction chemotherapy. On the other side, if you apply induction chemotherapy, this is also a selection bias, because if the patient hasn't progressed under induction chemotherapy, this is no candidate for surgery. But once again, in my personal view, if you have somebody with advanced disease with lymph nodes, induction chemotherapy does not have any advantage in these patients, because surgery is most probably in these patients dismal. If you go to the BTS guidelines, they do not offer what's partial pleurectomy over talc pleurodesis. They do not offer EPP, and even pleurectomy decortification is only recommended in clinical trials. If you go to the ERS, ESDS, EACTS, ESTRO guidelines, they recommend that all surgical patients should be registered in registries or should undergo clinical trials so that we can get more information about this dismal disease. And surgery should be only applied to highly selected mesothelioma patients, and it should be performed in centers of excellence and as part of multimodality treatments. And in this guideline, sarcomatoid or sarcomatoid predominant histology and 2 disease and stage 4 is not a recommendation for surgery. Then I want to present you something from Germany. We have there a phase 2 trial in patients with mesothelioma. And we have a commitment. Surgery should be upfront in patients where you can get out of surgery with microscopic complete resection. What we do is we have malignant pleural mesothelioma patients at stage 1 to 3, ECOG status 0 to 2. They go cytoreductive surgery in terms of EPD. HITOC is possible. And if these patients have a microscopic complete resection, they are randomized in 2 arms. Arm A would be the standard platinum-based chemotherapy with pemetrexed, compared to platinum-based chemotherapy and pemetrexed with nivolumab. Unfortunately, microscopic complete resection has a grading in this study, and this grading goes from CC0, cytoreduction, completeness of cytoreduction 0, that means no residual tumor nodules. This would be, in my personal view, the only situation for microscopic complete resection, but the score goes up to CC2, where you can have residual tumor nodules greater than 2.5 millimeters, but less than 2.5 centimeters. In my personal view, this is not microscopic complete resection. However, this cytoreduction score is true for most of the studies, so that this is a potpourri of patients where you declare patients microscopic complete, but you have still tumor left inside the chest. Nonetheless, this trial is ongoing in Germany, and we have at the beginning 12 participating sites across Germany. And last month, Heidelberg was at first place with 8 patients included to the study, and our institution was second place with 7 patients included to the study. And we hope that we get the study closed most probably by the end of next year, so that we can have new data about multimodality treatment in these patients. The most important thing for these patients is the maintenance of performance status. This is not true only if you have patients with advanced clinical stage or sarcomatoid tumor, or if they are medically inoperable. For these patients, there is a recommendation: if they have a performance status 0 to 2, you can do whatever you want, apply systematic treatment. But if they have a performance status about 3 and 4, best supportive care. I think this certification is true for every time period and every stage of the patient. That means if somebody consults me about treatment, I want to offer the patients a treatment where their performance status can keep very low, so that we can offer him more treatment at the next stage of the recurrence. So this is the most important part, that the patients have a prolonged survival. Maintenance of performance status, so we can offer the patients the treatment they can have. If we apply bad surgery, the patient has performance status 3 or 4. He is not able to tolerate any more treatment. But if we apply less invasive surgery, keep the morbidity and mortality low, then we can keep the performance status low. He can get more treatment. So if I sum up my experience for the management of MPM, I would say, and I would reply the advices of Hippocrates: as to diseases, make a habit of 2 things: to help, or at least to do no harm. Second point, extreme remedies are very appropriate for extreme diseases. Sometimes we have patients, they profit from 3-modality treatment, but sometimes we have patients, they do not tolerate such kind of extreme remedies. Of the several remedies we have, the physician should choose the least sensational. It should be a treatment appropriate to the patient, appropriate to his performance status. And to do nothing is sometimes a very good remedy. If you have a patient with performance status 3 and 4, please do not harm and do not offer any treatment to that patient. Thank you very much.
Thank you. Thank you for your nice presentation, Servet. Is there any questions from the audience? We have a question from Bedrettin Yıldız Edi, who is surgeon, thoracic surgeon, interested in pulmonary thromboemboli surgery, thromboendarterectomy, but he's a good surgeon for all thoracic diseases. In era of modern thoracic surgery, why the survival of MPM is still poor?
I think there are 2 important things. The first thing is, it's a rare disease. That means the money from all the companies, drug companies, they do not go in such kind of rare disease because they cannot earn a lot of money with very rare diseases. The second point is, as I said before, we cannot apply the surgical principles for oncology in these kind of patients because we do not have safety margins. That means at the end, it's macroscopic complete, but microscopic incomplete. And we would not accept this situation in any other cancer.
Okay, we have another question from Muzaffer Metintaş. What do you think about IMRT with chemotherapy or immunotherapy after PD?
I think both things are very good options. At least in Germany, we have problems to find radiation oncologists who are willing to do such kind of treatment because it's very time consuming for the radiation oncologists to prepare the protocols for these patients. And as I said before, it's a rare disease. Therefore, there is no real interest in, at least in Germany, to develop better protocols in terms of radiation oncology. But I think if you look at the data from MD Anderson from the United States or Memorial Sloan Kettering, Dr. Rimna et al., they present very convincing data that such kind of protocols are worth following.
Okay, thank you. Yeah, please.
Servet, I hope it's, I'm sorry, I had to join late. I was stuck in another meeting. It's too bad to be.
Nice
I really would have enjoyed it, but I just would like to share a couple of experience and plus some your opinion. One of them is this: immunotherapy has changed a lot of stuff in biphasic and sarcomatoid. we really do see some patients who get amazing responses with immunotherapy, like almost complete pathologic response in the PD specimens. So the classical approach is doing a macroscopic complete resection and followed by chemo or upfront chemo, flarectomy, decortication, as you have shown in many of your studies. But we have come to a certain point, but we can't advance beyond that in terms of survival. There is a recurrence rate and everything. So do you think we will, how would you change your protocol? I mean, like upfront chemo, what would be your next trial in terms of the new options? Because I mean, we are already stuck in a certain survival rate with the available treatments. What would be your next protocol that you will apply in your clinic in the next 5 to 10 years to test the results and to test the outcome?
Yeah, one thing is we still have patients who underwent induction chemotherapy or induction immunotherapy and presenting with their CT scans, consulting us if we are willing to perform surgery. If we have a major response, and you cannot hardly see anything on a CT scan, I refuse surgery because I don't know if I can help this patient to survive longer, including surgery. But the other side, as I mentioned before, this NICITA trial is very interesting because we have two group of patients. If I go back, we don't really know if the patient profits more if we apply chemotherapy before surgery or after surgery. I hope the ORTC study will give us an answer. But at the end, in Germany, we have a commitment, at least at these 12 centers, that we apply microscopic complete resection. That means at the end, complete response to the treatment. Then we apply in one group standard chemotherapy as in any other patient now also, but in the other group, including immunotreatment. And we hope that the patients with immunotreatment do better. Then this would be a good answer to the all arising questions in our heads. If we have this, then we can talk about maintenance treatment with immunotreatment till progression, then change the immunotreatment. There are different drugs responding to, and the mesothelioma is responding differently in different immunotreatments. Therefore, we could play with the different immunotreatment options. Then we have, if we have a long maintenance treatment and there is a progression, then we could once again apply chemotherapy. This is at least what we do in Germany. But you know, as you said before, we stuck there in 30 months median survival. Yeah, sometimes it's 32, sometimes 28, but it's more or less 2.5 years or 3 years in general, but nothing more or nothing less. You're absolutely right.
Yeah, please.
Good evening. Thank you for the great presentation. I have a question. Which material do you use as a replacement of pericard in case of an EPP on the left side?
Yeah, it's different. Sometimes we still use Gore-Tex material, but we try to avoid pericardial resection, performing pericardial splitting, or we use also mesh, which is used in general surgery as well, and it works.
Mm-hmm. And may I add, Servet, we use sometimes even proline mesh, and it works if we don't have anything other. Although
yeah,
it's
of course,
irritant to the myocardium, we probably have a slightly higher rate of arrhythmias, but still, it works. I mean, just something to block the pericard, the heart from herniating, right?
And you know, the cheapest material is the best material.
Okay, Thank you. We have another question from Ülke Yılmaz. Is there any patient group you prefer induction chemotherapy?
If the patient is treatment naive and presenting with his diagnosis of mesothelioma, for a couple years ago, I recommended always induction chemotherapy if there was an advanced disease or lymph nodes on the CT scan comparable to lung cancer. But if at least I look at my experience, they do not have a real response and downstaging what we expect from lung cancer treatment. Therefore, I do not see a need for induction treatment in order to perform surgery at the second stage. If something has an advanced disease, lymph node metastasis, then I recommend non-surgical treatment.
Okay, thank you. We have another question from Ibrahim. In case you decide to apply surgery stage 3 with epithelioid or biphasic histology, would you apply VATS to contralateral site or laparoscopic to exclude a diffuse disease if it's not clear in PET-CT?
If there is no clinical sign for abdominal spread or contralateral site spread, then we do not perform thoracoscopy or laparoscopy. Because we have also these patients becoming or getting mesothelioma on the other side a couple years after the initial diagnosis of the contralateral side. But there is still treatment options. We do not do harm to the patients if this contralateral site is affected in a couple years from the initial diagnosis. Therefore, we do not see any benefit for the patient if he has no clinical sign. If he has a pleural effusion or ascites, then of course we would go for laparoscopy or thoracoscopy. Otherwise not.
Yeah, please. Yeah. Sorry. Can I ask, please? Thank you. Sorry. Can I participate, please?
Yeah.
Yeah, please.
Okay. Thank you so much for a great presentation. A lot of information. I appreciate that. Thank you so much. From my question, I tried to write it, but I would like to explain what I mean. So you answered my question that you had some patients that they had contralateral side with this disease. So in case that you decide to apply surgery for example, stage 3A with this type of operable histology, because here you mean curative intention to help the patient, as you said, would you apply as prophylactic the contralateral side pleurectomy only? Would you advise that?
It's a difficult question. We do not have data for that.
Yeah.
I can remember we applied prophylactic pleurectomy to some patients with high exposure to asbestos, a lot of co-founding factors to be diagnosed with mesothelioma in the future, but we had no tissue confirming this disease. We did prophylactic pleurectomy. The pathologist was not able to find malignant mesothelioma, so I'm not able to answer the question because we do not know if mesothelioma would occur out of this pleura, or he would never get mesothelioma. It's difficult. If we have more information, especially from genetic point of view, like breast cancer, BRCA genes, and you know this patient will get mesothelioma, then we can talk about prophylactic pleurectomy, but we have no data for that to offer patients with high risk to get their pleura out of their body.
Thank you.
May I make one comment?
Of course.
I think the critical group here is the atypical mesothelial hyperplasia patients. We with Muzaffar Metintash, and we had several patients with known asbestos exposure, no proven mesothelioma, but had atypical mesothelial hyperplasia in the pleural biopsy. And it's a really big dilemma if we should go ahead and do a pleurectomy in these patients or just wait. But some of those patients with which we waited got mesothelioma in the end, a couple of years later. And actually, one of them had pleurectomy. There was no mesothelioma, and there was a mesothelioma in the cardiophrenic recess 4 years later, small place, and then it advanced, and eventually she died like 6-7 years later. So it's a really unanswered question, but it looks like with an atypical hyperplasia plus asbestos exposure, I think there might be some reason to be proactive rather than be or very close follow-up with CT scans, just any small thing. What do you think about it?
I would ask you to publish this kind of data because it's very important. If you have patients during observation, they get mesothelioma, we know if the disease is there, it's there. You cannot get rid of this disease. But it's not there, maybe we can avoid this disease. Therefore, if we have some high-risk groups, maybe we should apply prophylactic pleurectomy because, you know, from pneumothorax surgeries, etc., it's without morbidity and without mortality if you do a simple pleurectomy in these patients.
Yes, please.
I have another question. Dr. Bölükbas, for me, you are one of the leading persons in mesothelioma here in Germany.
No.
So I have, yes, that's true, for me at least. And I have one question. Do you think high talk has still value in mesothelioma? Is something that should be performed, should not be performed? Should it be a matter of patient selection? Or according to your opinion, if there is any revolution, the next revolution will be the combination chemotherapy and immune therapy? Thank you.
Thank you for this very important question. We have data on high talk. There are some groups performing high talk in mesothelioma patients, especially the Boston group. If you look at the data, yes, there is sometimes a significant difference with high talk group against versus non-high talk group. But if we compare this data with other data, patients with high talk have median survival of 25 months, 30 months, but there are also data out there without high talk, also 25 to 30 months. And I tried to show you the importance of patient selection. I mean, this is very important, what kind of patients were included in different groups. I would recommend to perform really a prospective randomized trial to get the real data. It makes no sense to compare retrospectively because we have a lot of data retrospectively, even with high talk, but not convincing. Convincing would be only prospective randomized. And we have the centers there. They should come together and put their patients in one study protocol, and that's it. I don't know why not. Especially the Boston group could do this kind of trial by their own. They don't need any other groups helping them.
Servet, may I ask one more question to you?
Of course.
With a lot of surgeries now, we see more and more biphasic patients.
Yeah.
It's most likely related with the pathological detailed examination. So what is your strategy? Because biphasic is absolutely a different disease. I mean, once you have a sarcomatous component at one place, that really causes a lot of trouble in some of the patients in terms of survival. What is your biphasic rate? Did that increase over the years in your series cohort? Yes,
it's increasing because we look for it. From the past 20 years or 20 years ago, it was epitoloid or not epitoloid, and nobody did go in detail. But nowadays, if somebody comes for consulting, we have the tissue mostly outside of our hospital from a different hospital. Then we sent this specimen to a referral pathologist to confirm the diagnosis. And it depends on the size of the tissue if we believe the diagnosis or not. If we have any doubts, let's do a redo thoracoscopy. It's about 5 minutes, but we get more tissue from different places, and then we can confirm this is really biphasic or this is sarcomatoid, but definitely it's not epithelioid. And then we can exclude this patient from maybe useless surgery.
Okay,
Ben bir soru
thank
sorabilir
you.
miyim?
Tabii.
Hi Servet. Seni görmek güzel. Teşekkürler. Çok iyi. Çok iyi bir sunumdu. I would like to ask one question about mediastinoscopy, of course, because I tend to perform mediastinoscopy before the operation. I agree that lymph node positivity is not like the lymph node positivity in lung cancer patients. But since the survival rates are not so good, as you showed very nicely, in almost every centers in the world, I use it for a selection actually tool for the patients who can benefit more and more from pleurectomy decortication. My question is, do you perform mediastinoscopy in those patients, in some patients, in selected patients with PET-CT positive maybe? And the second question is, do you or did you consider resection, pleurectomy decortication? Actually, I thought to perform resection in a couple of patients, but I was not so bravious to do that. And as a result of the second chemotherapy in those patients, I didn't need to reconsider to resection. But did you do any resection? And Hasan, maybe, did you do any resection, redo pleurectomy decortication? I'd like to ask Hasan also.
For the first question, mediastinoscopy in mesothelioma patients, no, I do not perform mediastinoscopy. I cannot remember any patient who underwent surgery having at the end of the day really lymph nodes in the upper mediastinum where I can perform a mediastinoscopy. I would do it, it would change the treatment. But if I have someone with advanced disease and lymph nodes, even in the upper mediastinum, confirmed by PET-CT, there is no real indication for me, at least for me, to perform mediastinoscopy to confirm that there is a tumor inside the lymph nodes. And the second question, yeah, sometimes there are possibilities to perform redo surgery, especially if there is a chest wall recurrence. It's a very easy surgery to do it, even especially if it's a young fit patient. It's not very demanding surgery if you do this. I can remember a nice surgery with mediastinal recurrence. Then I performed a hemiclamshell and I was able to resect the recurrence at the mediastinum. It was very easy to do that, but these are highly selected patients. We cannot say, yes, we do redo surgery in every patient, but occasionally, yes. But at the end, you have to decide performance status, what treatment options are possible. If it's a localized disease, then always consider surgery at the right era, if it's good accessible. But on the other side, do not harm. But Hasan has a lot of experience in Istanbul.
I think pretty much the same, Servet. I don't do mediastinoscopies as well. Only if there's a high degree of suspicion in the mediastinum, we do mediastinoscopy. I agree with you that PET-CT is pretty much accurate, and the mediastinoscopy can reach only a limited number of stations, and the lymph node spread in mesothelioma is different than lung cancer. So That's another posterior intercostal lymph nodes, internal memories. They are different locations. And in terms of PD, no, I don't think it should be extremely selective patient that you do a partial PD and then you decide to do a completion somehow. And it's quite rare, I would say once or twice in your surgical practice. But chest wall recurrence isolated, we do chest wall resections, we resect some of the local regional recurrences. But I would try to refrain from most of them because they might need radiation. Some of them can be handled with radiation. But I think Servet has to be congratulated for his extreme discussion with Sugar Baker, the rest in peace. He was an advocate of.
I remember.
You were an advocate of RP, radical pleurectomy, right?
Yes.
Eventually, everyone came to your word, not the other side. I do pleurectomies now. I haven't done EPP for the last 10 years almost. And our results are better. Maybe we learned the disease better, but still.
My advantage was that I learned from the failure others. I saw it does not work, then this was my advantage. I tried to learn from the mistakes others. I don't think EPB was a mistake, definitely not.
Yeah.
But it was a process to understand that, as I said before, keeping the performance status of the patients low is, in my opinion, the most influential factor for the patient. If he's fit, he can get another surgery, he can get radiation treatment, he can get another surgery, and he can get much more chemotherapy. And this is the time he gains, and this enhances his median survival. This is the only thing I believe.
And maybe one thing is the lung, however stuck or however collapsed it is, with a good pleurectomy, you will achieve a good lung expansion.
Yes.
Even if it's collapsed for the last 2 months, still it has a potential to be open. And within a month, maybe it will have air leak for some time, but still at the end, you have a good, relatively acceptable or good lung expansion.
This is very important. Thank you for your advice, because you have 2 points to consider. First thing, the patient has a very low quality of life because of pleural effusion and dyspnea. If you reach re-expansion of the lung, he has a better quality of life. And second, from performance status 2 or 3, he switches to performance status 0 or 1. Then he is a candidate for further treatment.